Welcome to the Love and Guts podcast, Dawn. I don't know how many times you've been on my podcast now. I think it's at least 5 times. It's got to
Ah,
be
yeah. Yeah, I was thinking maybe it was a
over the
fourth
years.
time, but it could be. Yeah. Yeah.
Yeah.
It's nice to be back with you.
I always love having you on. I always feel like it's a bit of a treat, personal treat. But for those who may not be familiar with who you are, I'm going to read through your bio, which I know people just love to sit through.
Yeah, you do
And
it in
like
your
I always like to say, my notes, my questions are up there. So if I'm looking up there, it's just, that's what's happening. So Dawn has spent over 20 years working in functional and naturopathic medicine, specializing in perinatal and early life health. She's a clinician, researcher, educator, and clinical mentor, trained as a naturopath, herbalist, and lactation consultant, which means she brings a uniquely integrated perspective to this space. Her academic contributions include peer-reviewed publications, textbook chapters, and co-creating the postgraduate evidence-based natural medicine program at the University, oh my God, of Tasmania. She's a sought-after presenter at international and national conferences and has contributed to ACNM's functional medicine training across topics including the infant and preconception microbiome, pregnancy nutrition, allergy prevention, colic, reflux, breast milk microbiome, and more. Dawn has been in busy clinical practice throughout, based at Gould's Natural Medicine in Hobart since 2006, and has worked closely alongside Dr. Jason Horlak for over two decades, bringing his paradigm of restorative microbiome care into the perinatal and early life space. She holds first-class honours for her clinical research in herb-drug interactions and was awarded a prestigious fellowship by the National Herbalist Association of Australia for her contribution to herbal medicine in this country. This is truly your life's work, and I'm so glad to have you here today.
Thank you. It's lovely to be here with you.
So, guys, we are going to be discussing a very important topic. We're discussing the pediatric microbiome, and there's a few tests that are coming out really investigating this space. So we're going to dissect the pros and cons of this and what to be mindful of as a practitioner, but also as a layperson that's interested in doing this for your children potentially. The infant gut microbiome is often described as being in a state of ecological succession, actively assembling rather than settled. Before we get into the testing side of it, can you walk us through what normal actually looks like across the first 2 to 3 years of life?
Yeah, absolutely. It's a great place to start. And I think, I guess key words for this time are there's a lot of change, it's dynamic, and it's I guess this cliche phrase that I like for this time is it's a journey. It's not just about the destination, it's also about the journey. So there seems to be kind of important steps that might have important health functions in the development of the ecosystem. So we have, I guess that appreciation as we're kind of considering it. And then also each individual infant is sort of on their own path. Like we have an appreciation of the patterns that we might like to see, but we kind of understand that they're kind of a little bit on their own journey as well. And the science is in its infancy. So like we know more about the microbiome than we ever had before, but really we actually have so much to learn. There's so many blank spots in our understanding. So to keep that, I guess, humility is really important. So what we do understand at this point is that probably the environment of the womb is probably sterile. There may be some interaction with maternal microbe products. So some of the short chain fatty acids can come through into the amniotic fluid, and also these extracellular vesicles, or EVs, not electric vehicles, but little vesicles that that break off from bacteria and have little parcels of potentially bioactive cargo in them, can actually be found in the amniotic fluid. So there's interactions happening with microbes in the womb, but at this stage we appreciate they're probably not live microbes there in the kind of healthy state. And then with birth we have this seeding happening, and that early post-birth microbiome is quite interesting because it sort of appears somewhat inflammatory in its makeup. Yeah. It's actually got quite a richness in proteobacteria. So, often we'll see quite a bit of E. coli in the vaginally birthed infant and maybe more Klebsiella in a cesarean birth infant ecosystem in that early post-birth time. There'd also be quite a bit of strep and staphylococcus, and these are called facultative anaerobes because they can actually consume oxygen, and that capacity they have to consume oxygen actually assists in the evolution of the ecosystem. So the oxygen in the digestive tract is consumed, and then this kind of helps the ecosystem to shift. And this chapter of kind of inflammatory kind of micropresence seems to be really important for immune programming and priming. So while it might look like problematic to our eyes, it sort of appears that a short stay in this is actually quite important and biologically normal. We'll also have a little, like I'm just missing the word, but we'll have a little bulge in Bacteroides growth. That'll bloom, that's the word, that'll bloom and then come down in these early weeks as well in the vaginally born infant. And again, we have this understanding this might actually be quite important for immune programming. But pretty quickly, for the exclusively breastfed infant, we see this shift into an ecosystem that's really guided by breast milk, and in particular, the feature that we understand about that is this bifidobacteria dominance, and it's quite a low diversity ecosystem. So we're always thinking that an ecosystem should be diverse, but during this kind of breast milk guided period, we see actually low diversity and this real dominance of the bifidobacteria that often kind of will be a community of bifidobacteria that work together to really hold that ecosystem. But what's quite interesting is during this time, we will also potentially see, persistence of E. coli, for example, and I guess we're learning that, that actually in a healthy infant where it's sort of held in check and its behaviours somewhat influenced by the factors in breast milk, that it may also have continual function at a kind of well, we would say low compared to the presence at birth, but sitting potentially up to 5%. So kind of enough that if you are not familiar with looking at infant ecosystem, that you could feel alarmed. And it's I guess because our understanding is just so still evolving at a first glance, we won't really have a sense of whether that player is friend or foe, but just to kind of keep in mind that seems to be a pattern in healthy infants up until 6 months, that it might sit up, coming up to 5%. So we have that important breast milk dominated chapter with the high bifidobacteria, and we have this awareness that it's a chapter that we don't want to rush. We want infants to have their full time in that chapter, and that chapter will be shortened if we have earlier introduction of solids, or if formula supplementation's coming in, it'll be shortened in terms of how quickly the infant will leave that chapter. And getting into that chapter will be delayed if there's been a preterm birth, or cesarean birth could be a bit delayed if there's been earlier formula supplementation, or antibiotic exposure could be delayed. So I guess it really comes back to the importance of protecting and promoting and making sure families have access to good breastfeeding support, so they've got the best possibility of being able to have that solid exclusive breastfeeding chapter. When everything, any barrier that's there, whatever we can do to remove those barriers is so worthwhile on our part. Totally. And then just to finish the story of this ecosystem, we have another really big time of change at around 6 months. The solids are coming in the normal kind of situation. And ideally, we want to see the solids coming in gradually in terms of volume, so that we're not diluting the kind of the hold that breast milk has on the ecosystem, and also all the other ways that the breast milk has, bioactive function for that infant, developmental programming in so many ways, not just through the microbiome. We can get very excited about the microbiome when we're excited about the microbiome, and forget that it's, that breast milk is this kind of wonderland of bioactive substances that we're, just new substances are being found all the time. So
The ultimate gardener, as you've mentioned
yes,
previously in podcast
yes,
9.
I think this is a good way of describing it, the ultimate gardener.
Mm.
Yeah, so, and I guess that just reminds me, talking about substances, just recently a substance was found, that another substance that helps to kind of deactivate LPS. So I guess that's quite interesting, that breast milk is, full of all these components that modify how the infant experiences some of those inflammatory microbes compared to a system where we don't have that breast milk in there. But
Mm.
yeah, coming back to the end of this chapter, when you've had exclusive breastfeeding and then the introduction of solids, hopefully happening gradually, we then see a shift in the microbiome at that point where it starts to diversify and we have new taxa coming into the equation. And that's largely because we have the introduction of other fermentable substances that these microbes can eat. And also during that time, we've got still kind of seeding from breast milk, where we're actually getting kind of continued exposure to microbes that might originate from the mum's digestive tract, and then combining that with these new kind of fibers and elements from their diet, we might see, then those microbes taking up more of a niche in that ecosystem. So yeah, that diversifying chapter, actually, I mean, people are trying to put a time frame on that, and there's sort of suggestion that, originally it was like, oh, maybe it's when you're 2 that it's kind of you becoming more adult-like, and then it was, oh, 3, and now there's researchers saying actually it might not be until it's more like 7 that the ecosystem becomes
Okay.
more adult-like and kind of more settled, I guess.
Mm. And I know that I've heard you say in the past on the podcast of mine that when when babies are breastfed, they almost take on that adult picture a little bit earlier, or just
When they're
um,
not breastfed.
yeah, when they're not breastfed,
Yeah,
and they're
that's right.
formula
So the
fed,
ecosystem can skip ahead. So I guess that thing of wanting that nice period of exclusive breastfeeding, and
if
when
at all possible.
yeah, when that's when there's earlier introduction of solids or there's formula supplementation, we see that ecosystem skipping ahead and kind of moving into that next phase earlier than
Mm.
we would hope for.
And that like inflammatory picture, I guess, in the gut of a newborn,
Mm.
how long does that kind of, is that like up to 6 months we're seeing that, or is it longer? What sort of time frame are you kind of seeing those inflammatory species?
Yeah, I mean, I think that it's like there's a lot of variation here, but I think you see pretty dramatic changes over the first couple of weeks. Yeah,
Yeah.
so yeah, and I think like it's amazing if you look at the studies where they've sampled the infant ecosystem, like every week you see like every week a dramatic
Wow.
change up into 12 weeks, and I guess that's very useful information for us clinically if we're thinking about
Totally.
testing too.
Yeah.
But yeah, I mean, typically the prominence of those inflammatory microbes is coming down within the first 2 weeks, and
Yeah.
probably for some infants within the first week, but within the first 2 weeks, but it might be sitting at a midway point, I guess, at 4 weeks, and just depending a little bit on the individual, it might take a little bit longer for that shift to occur. But
Mm.
I guess it's evolving.
Yeah. So you shared a story about a baby whose microbiome shifted dramatically in just a few weeks without any intervention at all, and it sort of had to do with Klebsiella. How common is that kind of rapid, spontaneous rebalancing? And you've mentioned here it can be, within a couple of weeks, there's massive shifts. Um,
Mm,
so what does that tell us about the clinical risk of testing too early and acting too fast? Already,
yeah.
as you're speaking, I'm like, oh, okay. Well, people really need to be aware of these things before even suggesting a test on someone, a pediatric test on someone, a microbiome test. But yeah, I would love to hear the story if you don't mind sharing that. And
Yeah,
also,
sure.
yeah,
Yeah.
yeah.
Yeah, I mean, that was quite a formative story for me. It was like quite a number of years ago, I think early on when, tests were just becoming available. And yeah, I had this family come to me that were really deeply worried because they'd done this test on their infant and found, 25% Klebsiella, and, bifidobacteria was only at 18%. And yeah, they wanted to intervene. They were pretty panicked. They were an exclusively breastfed infant. Interestingly, this particular infant, was, a vaginally birthed infant. So we didn't see like a story of disruption, which I found, is an interesting kind of aside. But that by the time they came to see me, the test was, like I think almost 4 weeks old. So I was like, well, luckily I had the foresight and the instincts to be like, okay, I think we should retest before we do anything. And like, I felt so tempted to intervene because it was kind of an alarming picture, but I just sat on my hands, which is, I think, something a really important thing we can do as clinicians. We kind of undervalue that, just pausing and, and not interfering, and just kind of really taking a moment to just see what you're actually dealing with and see how biology's kind of sorting this situation out itself. So we got that test back pretty quickly, and it was, I was just kind of, I felt quite blown away at the time because the bifidobacteria had just risen up to in the high 60s, and the Klebsiella had just come right down, and then at a follow-up test it was completely, below detectable levels. So it was just a really valuable learning experience early on that was quite formative for me. And I think it's really backed up for me in my clinical experience also with many of the families that I have done testing for. It's because they're very worried about their infant's ecosystem. They've had a cesarean birth, or there's been just, a bunch of antibiotics, or, microbiome disturbing events, and they're feeling, that their infant's ecosystem must be, damaged, or the other kind of common belief is, my gut's in terrible shape, so I know that my infant's going to be in terrible shape.
Yeah.
But what I see time and time again in practice is actually if we do, in this situation, and this is, I guess, one of the reasons where I may kind of consider testing to provide this reassurance, is we do the test and we find that this beautiful ecosystem, we get that kind of that feedback that actually the ecosystem is looking beautiful. This is in those exclusively breastfed infants, so biology's had a chance to kind of, with that microbiome resilience that we know is present in that system, for things to course correct and come into a good place. Part of that, of course, is if you test right at the time of the disruption, you're probably not going to get to witness that. There needs to be some time for recovery. But yeah, I mean, and I guess when you're thinking about that time frame, I think that's a really important bit. And maybe I'm jumping ahead, so I'll let you come back to your next.
Well, I'm glad you answered it like that, because I was going to ask what was the intention behind the family wanting to test. So makes sense if they're well versed around the vaginal births versus cesarean and the seeding of the baby and all that sort of stuff. They're wanting to investigate that, as concerned and empowered, well-informed parents. At what point did they do the test? Was that like as a newborn? Like when?
Well, they're actually a bit older than I went back to check, and I think they're around 8 weeks. So it was actually kind of
still, that's foresight.
Yeah, I mean, I guess it's the time microbiome, with the people just thinking about the microbiome, it's hot, and I think other family members were getting it done, and so they just kind of, they saw it as part of care. And you can think, well, if they hadn't done the test, it would save them a whole lot of stress and worry, because really they did the test and then we're like, okay, we need to retest to put that in context. And the other option would just not test at all. And this, I mean, this family hadn't had a microbiome disturbing event, which is interesting. You don't really know what was happening with that ecosystem.
Oh, so this family had a vaginal birth?
Yes. Yeah.
Oh, okay. Sorry.
Yeah.
Yeah.
Okay. But I guess what I'm saying is that I see a lot of families where there has been quite disturbing events, and then they want to test the ecosystem, and they're like, oh wow, look at that.
They were more just curious.
Yeah, exactly. Yeah. Yeah.
So really important for practitioners as well as everyone else that might be thinking of doing this, that to just listen to these pros and cons, because you could just have this unnecessary fear for no reason. And like you said, there's patterns in an infant's microbiome that kind of can look alarming, but it's so common that we see that there's a purpose to it. You know, it's not just there by chance or mistake.
Yeah.
There's a purpose to it.
That's right. And there's not, it's not like all Klebsiellas are the same, like that
Yes.
Klebsiella could have been a particular strain. It's, it's in that environment where the breast milk is influencing its behavior, and, bifidobacteria is just steadily rising up, maybe slower than we expected. But as you say, we don't know all the elements of that ecosystem and what's occurring there. So
Yeah.
yeah.
Where do I go from here? So are there clinical scenarios, specific symptoms, presentations, or contexts where microbiome testing in an infant or a young child genuinely are useful, and changes your clinical approach if you do them?
Yeah, I mean, I guess I feel like there's probably like four different reasons why I might test. I mean, one is when like that family's going to do it anyway, and I'm like, well, I might as well come along for this ride.
And guide you.
Yeah, exactly. Rather than you go off to I don't know where, and who
Throw
knows
everything at it.
where that ends up. So, and I feel like I can hopefully, provide some context when that result comes in, advise them to push out the timing of when they do the test so we're not doing it too early. I think if we do it more, after 12 weeks, where that ecosystem's had a little chance for things to set, to shift and evolve, and it's in a bit like it's still changing a lot, but is a bit more stable at that point. Or if there's been a disturbance that we've given enough time to see. And I think, I would say 3 or 4 weeks after a disturbance at least, to be able to see, how that ecosystem's recovering. And I guess the other part of that is also being aware of the family's financial state and if they can afford to do a follow-up test. Because if you pick up on something, you often do want to do a follow-up test. And that's really important, I guess, to track what's going on, but also for kind of reassurance for that family as well, for them to be able to see, that ecosystem repairing. So that's one reason when they're going to do it anyway. When there's an infant that's not receiving breast milk, and of course that first of all, when you have a family in that situation, I wanted to explore and understand why and see if there's a way that we can support breastfeeding, remove the challenges that are, perhaps at play there. But I feel like there can be a place for microbiome testing in that setting. I mean, I think a lot of, that family may not have the means for it, so really need to weigh that up, whether they actually have the means for it and if that's an okay use of their funds. But in the situation when they do, I guess if they've got the means, they might actually, we might be able to explore other options in terms of, access to donor milk and things like that. But yeah, in this situation, it might influence the pre and probiotics I use to support that infant, depending, we can see what's persisting in their ecosystem, whether we're feeding the bifidobacteria that they have acquired, or whether we are feeling like we need to do something different and try and kind of work to bring in some engrafting bifidobacteria if we can. So that would be, I guess, a specific scenario that I would. And then that story when there's been substantial microbiome disturbing events and they're an exclusively breastfed infant, or an older infant that's having breast milk and solids. If there's been a lot of disturbing events and and also there's a clinical picture of like a severe eczema or other reasons to sort of think, well, maybe we should check the ecosystem, I might do it. I might recommend it in that situation, or often it will be parent-led in that situation. They'll be curious to, and then we'll kind of discuss it. And often in those situations, we do find we get reassurance. We get that ecosystem, that report back, and we're like, wow, the ecosystem's actually looking really good. But, very occasionally I have picked up on an ecosystem where I feel like I watch it, I might do a second test and I feel like it is warranted to intervene. It's not common. Then it's like actually, 3 times ever I've been in that situation. It's not, and I've seen a lot of babies, so it's very unusual. So I think, in this scenario, I think, it's very reasonable to confidently reassure that family that your baby's getting, the ultimate gardener. If they're a breastfeeding infant, we know that breast milk's going to be, seeding your gut with microbes. It's going to be providing all those prebiotics to selectively feed the bifidobacterial species that are going to be beneficial in that ecosystem and other microbes that are beneficial in that ecosystem. And it's got all the factors that are going to be suppressing potential pathogens or unhelpful microbes there, so that, they're getting already the perfect symbiotic, and we can confidently reassure families of that. And we don't need to be kind of saying, I really think we should test to check. I think that's, there's not going to be many babies where you end up deciding to do something other than to support breastfeeding in that situation. And then the other time where I might test is when there's kind of a clinical scenario of recurrent urinary tract infections, or severe eczema again, or a gastrointestinal allergic presentation. That would be more common in an older infant or toddler. And I feel like at that point, there's more reasons for that ecosystem to get off track. So it can be quite helpful to test at that point.
Yeah, absolutely. And that was going to be my question as well. Like with the older children, like 5 years and older, would you be more inclined and more comfortable to be testing in that environment, because it's maybe a little bit more settled to a degree, and also, there's specific conditions you might be working on, and they might have a bit more of a robust microbiome.
I think that's a big part. It's more settled, and maybe we also just have more data to understand, how we can support that ecosystem. Yeah.
I was going to say maybe more easier to take a stool test, but maybe not. Maybe more easier with a little baby versus a 5-year-old. Well, I'm thinking of my 5-year-old versus my 2-year-old, who's going to be the easier one.
Yeah, they can be possessive of their stool at 5.
Oh, I think Ava would be quite excited to do something like that, to be honest.
Yeah.
I did do my stool test this morning, and she was very curious. I had to lock the door. I'm like, honey, you're not coming in for this. No.
Well, that's one way to get them curious, modeling it.
Totally. She was very, very curious. Why do they call them stools? Isn't it poo? Like, good question, because it is a bit of a funny name to be given.
It is,
given poops. So the new pediatric biome tests that are available out there investigating the gut microbiome of that population cover 0 to 3 and 3 to 17 years. These are enormous developmental windows. The early life microbiome is a highly dynamic one, which we've spoken about. What are the risks when we try to compare a 6-week-old and a 2-year-old against the same reference range? And I will say here, like, I'm actually grateful that there are these tests available, because some practitioners might have been using the adult reference ranges, and you're trying to sort of put that into perspective with the younger child. So this is better, not it's perfect, but we're going to constantly refine it, right? Like, it's going to get better, hopefully.
Yeah, absolutely.
Yeah.
I mean, I think from 0 to 3, like, there's so much change from 0 to 3. I feel like if you're looking at the changes happening there, it's actually kind of more change happening in that period than if you're comparing, in my opinion, like a 25 to a 70-year-old.
So it is almost redundant, that, like, what would you like to see?
Well, I think first of all, I feel kind of conscious that we need to be thinking about where the reference ranges are coming from. Like, what's that populate? Who's that population that it's based on? Like, where's that data coming from, and how relevant is
Do we know?
To the population? I think, like, some labs might have their like little set of healthy individuals that they would kind of use that as the where that reference range was derived from. But I guess with infants, like, that's quite complicated, because we need to be thinking about, like, their age, their birth mode, their feeding mode, antibiotic, like, all the things that would be
Influence.
impacting their ecosystem. And I don't trust that's all being like carefully, there's a careful selection process where we've got a reference population that actually represents health. And then also, I guess the other element to this is there's just so little we know in this area too. There's like, sure, we have some things that we've worked out, the importance of this bifidobacteria prominence, but there's so many things that we don't know, and they will be quite individual specific. So if we have a formula fed infant who has, I don't like a prominence of proteobacteria or prominence of E. coli, or even, perhaps, even that 5% E. coli, that's quite different to a breastfed infant in terms of what might be going on and how that might be interacting with their health. So I guess that's one element of it, and I think that I think it's easy for us as practitioners to pick up that that report and see the reference range and kind of easily kind of presume that it's accurate. To be blunt. I mean, we've got the problem that you can't actually unless you're just going to have really wide parameters. If you're going to include 0 to 3-year-olds, you have to just have, okay, well, it's normal for your E. coli to be 30% to 0, like you have to have pretty wide reference ranges if you're actually reflecting that whole population, which isn't very useful. But then I think we do have this problem of, how do you, like, because the science is so, we're so early in the science of inquiry on this and defining what normal is, having like a reference range that you could actually apply. We're not there yet. So I think what I would really like to see is just clear communication of like, this is our reference population that we've used. This is how they're defined. Your result is above this reference population's result. We don't know what that means.
Yeah.
like it might be good, it might be bad. We don't know.
Yeah.
Like rather than kind of a very like something that feels quite prescriptive to me, when I don't think that there's the foundation of knowledge and evidence to really actually support it. And yeah, in terms of like, what are the risks of that? Well, the risks of that are misreading the results, false assumptions, and then acting on false assumptions, and parental stress. Like I mean, I'm sure you've experienced this, when parents see things in the red or outside, it's very stressful for them. And it's the thing they see more than anything else. It's the thing that goes in more than anything else. So if it's like just kind of hypothetical, then that's even more. I mean, I feel like the drama needs to be pulled right back anyway. But if it's hypothetical, then that's even more concerning.
Which just highlights to me that the practitioner using these tests really needs to be trained, because you don't want to be just hanging your hat on the reference ranges. You kind of want to be looking at it with all those confounding factors, all those, those in context to what's going on for that individual, how old they are, breastfed, not breastfed, all the rest of it. Like, I think it's just kind of almost, it's a little bit redundant to a degree. Nice to know in context, like within like the realm of what they've discovered in their population. But like you said, it's an evolving area, and it's just you really need to kind of be able to be the practitioner that has been trained, that looks at that data and it's like, okay, well, we can see that this is going on there, the bifidobacteria species are down. Okay, this is what we can do there. That's kind of interesting. But I just think, I can see so deeply the importance of being trained when you are investigating using these things.
I do think you need to take it on like with both hands if you're going to order the tests to be ready.
And that kind of 3 to 17 years, are there kind of major shifts in the microbiome there, like when
I think 3 3 is quite different to 17.
Oh, totally.
So, I mean, you agree with me there, but
Yeah. Yeah,
I've
absolutely.
had both of those people in my house, 3 and
Yeah.
17-year-olds.
And also
But
some 3-year-olds still might be getting breastfed,
exactly.
So
Well, you're
there's
still in that early, you are kind of, that
mm,
ecosystem is, yeah, it's still kind of close to infancy. It isn't, yeah. I think that if that reference range was 7 to 17, like maybe that would be, a bit more,
yeah,
like
make a little bit more sense.
reasonable. Yeah. I mean, yeah, I think it
Too
it's
large of a gap, too much
yeah.
going on between them both. So these reports also include markers like fecal calprotectin, zonulin, secretory IgA. Calprotectin typically runs physiologically elevated in infants. How do you interpret these markers in context, and when does including them in a report do more harm than good?
Yeah, I think that's just such an excellent question. Like I just would not order fecal calprotectin or zonulin in a child under 3 years old. Like I just don't think it's a useful test in that age group. And it's so interesting with fecal calprotectin because it'll be higher in vaginally born infants compared to
Mm,
cesarean born infants, and it'll be higher
that's
in breastfed
fascinating.
infants compared to formula fed infants, and it will be lower if an infant's had antibiotics. So it's really, um, it doesn't align with what we know as healthy features for this population. So I think yeah, I just don't think it's useful to have it there. And I think it's really understandable that practitioners would assume that a high fecal calprotectin was, a problem because that's, you don't
Kind of is in the
necessarily,
adult in a way sometimes.
yeah,
Yeah. Yeah.
yeah, and you don't, just I guess that nuanced information you don't necessarily have. So yeah, I guess I yeah, I think it would be better not to include them in tests under 3-year-olds or just have extremely clear. I think it's better not to include them because parents are going to get anxious as well.
Yeah, they'll
And
just
then
jump on Chat GPT and,
yeah,
you know, ask the
exactly.
question, what does this mean? And get a stream of, okay.
Yeah, yeah. And I think, all the other markers, we have to appreciate that it's a totally different context. So, that will be, lactoferrin, what's normal will be different, and secretory IgA, what's normal will be different. And some of it is not, we just don't have enough data to understand what it looks like. We just know that it's different.
Mm.
Yeah.
It's so interesting, isn't it? That sort of infant microbiome really has that inflammatory marker sort of pictured, isn't it? And
Mm-mm.
pattern. Even
Yeah,
down
well,
to the
like I was saying, there's
calprotectin,
like
it's like,
immune development happening, and it kind
yeah.
of yeah,
It's like
yeah.
you're born into this world, like be prepared. We need to just
Yeah.
we'll give you the information now so you know how to deal with it. Yeah.
Yeah. Yeah. Although, like, maybe there's just another way of measuring inflammation in that population that would be more
Mm,
accurate. Because, like in reality, like the formula-fed infant has more inflammation in their bowel. It's just that it's not captured with the fecal
yeah.
calprotectin.
Yeah.
Yeah.
That's so interesting.
Yeah. It
And
is.
is there some theories around that at all?
I mean, I think yeah, it's really about I guess, the immature immune system and, gosh, now you're testing me. But yep, there is some more theories about that. I'll have to come back to
Sorry to
you.
put you on the
Yeah.
spot. um, so where does the evidence currently sit on organisms like blasto and dientamoeba fragilis in the developing
Mm,
gut? Because
yeah,
I
I
know that
feel,
if parents see that under the pathogen, they'll be like, oh my God, what do we do
yeah,
about this? This is alarming.
they're very normal part of the pediatric gut ecosystem. And
Mm,
I feel like we don't really know enough about the infant gut ecosystem. I don't really yeah, there hasn't been that much inquiry into that, but certainly with pediatrics and probably familiar with those correlations with the presence of them and being correlated with a healthier
healthier
microbiome,
gut.
which
Yep.
which is
And adults
interesting,
as
isn't it?
well.
Yeah, yeah.
Mm. And again, like we used to think that they weren't.
Mm,
Um, They were just, if
Yeah.
they were seen on the report, they needed to be dealt with. So how much has it evolved, our understanding of it
Yeah,
since that point in time?
exactly. And
Um,
what could come up in future? And I guess that's just to kind of quickly go back to, because there's something I forgot to mention before when you were talking about the reference ranges and the kind of the risks of having these reference ranges that don't apply. I think that, you know, the other kind of related issue is when you see a microbe that you think, would normally be pathogenic in a adult, where you kind of feel inclined to want to address that, and maybe more
mm,
inclined to address it because it's an infant,
yeah,
when actually it could be, just most likely it's just, part of that ecosystem, and actually we should just stand back.
yeah.
Yeah.
Like a midwife, just let it
Yeah.
be. So you've spoken about Bifidobacterium being the keystone genus in the infant gut. Is there specific Bifidobacterium species that matter most? And why do they matter? What do you look for, or which tests would show around this group?
Yeah. Um, I guess, I mean, it is really interesting to have the species level data,
Mm,
definitely. So that's helpful, I think, when we're evaluating who's there. With regard to the infant, like the bifidobacteria we want to see there, we want to see those infant specific bifidobacteria, and they're the ones that are able to consume and metabolize human milk oligosaccharides. And the ones that are kind of well known are B. breve, B. bifidum, B. longum, and B. longum subspecies infatus, which is probably the one that people grab onto because it has got, I mean, it's a pretty amazing species because it's such an efficient consumer of human milk oligosaccharides. But, I think that kind of this idea that that might be the most important one, I don't agree with that concept. I think it's really fascinating when you look at, say, Bifidobacterium bifidum. It's kind of community-minded bifidobacteria. So it like kind of does its digestion a bit on the outside of of the bacteria, so that it's sharing substrates with other bifidobacteria. So it and Bifidobacterium breve are like good mates, and so the presence of bifidum can just lift up not just breve, but other bifidobacteria species. So it's kind of a real community player. So
mm,
I think, I mean, that's just getting into too much nuance, really. But I think it's fascinating to think how they, this idea of them kind of being collaborative in the way they
yeah.
work to build up their numbers. And so those are the species that we know about, but then there'll be other strains as well, like within other species that just happen to have the capacity to break down HMO. So, there's, I guess, some strain level, capacity for that within other bifidobacteria species. But it's good to see like a good level of these bifidobacterium as far as we understand, and we understand that they play a really important role in kind of helping with gut barrier maturation, and they sort of help to keep the inflammation down as this evolution is happening, and their abundance correlates with metabolic health and neurocognitive health, and also, immune health, less allergy development and things like that. So it does seem like they're really important. I think another element of this is it comes back to that having respect for biology. I feel that and not just it's just my feeling. There is also kind of researchers sort of saying, that family origin bifidobacteria strains will have a natural fit to that individual baby. So the microbes
Amazing.
that they pick up from their family members will, have a good fit with them in terms of their genotype and their environment. So I guess that's another reason for standing back, because we're like, oh, these infant-specific bifidobacteria are so good. Let's just give them, let's just supplement babies with them, which you see that in stores everywhere, don't you? You've
Mm,
got to have your baby biotic. But I guess, when you throw something in there, especially if it's, say, Bifidobacterium infantis, is it going to share with the local, like with the family origin Bifidobacteria, or is it just going to like dominate
Take
and
over.
kind of take over? And, what have we ultimately done? Have we helped that individual, or have we potentially, have we possibly had a negative impact? And I guess that's when you have that question, you sort of feel you really should sit back and watch a bit before
Mm.
interfering.
So do you see any, like, what are the big benefits of testing like this? Because we've spoken a lot about the concerns,
Mm-mm.
and how we really need to enter into using these with awareness and education as a practitioner. Um, and also, I think as a person interested in doing this for their children, to work with someone that is
Mm.
able to interpret the report correctly and guide you is really, really important. So, are there any benefits that you see with this? You've mentioned when you would use it, but
Mm.
are you excited by any of the parameters in there or the things that are tested?
Um, oh, it's a really interesting question, Linda.
Or is it a
Um,
blanket? No, not at the moment. Not the state of it.
I'd just be like totally lab neutral. Uh, I think there's a place for it. I do think I'm worried it's going to be overdone. I'm worried there's, going to be a real influx and uptick of recommending these tests. And yeah, I do feel a concern about how that might play out and impact the
Mm,
families and infants. But absolutely, there's times when I feel like they can be really useful in, picking up on something that might be affecting a clinical presentation. So I think that's, I guess, the time where I felt like, that toddler, that young child with, a really bad case of eczema, and then you do their microbiome analysis and you're like, okay, you see some things that you can work on. You could just, really help them with some prebiotics to feed up their existing population of bifidobacteria and see a shift in them. Yeah, those would be times when I guess it could, um, I think you could say, yeah, the pros outweigh the cons. But I think it's easy for us to just get it, kind of curious and excited. I'm like, oh, I'm curious about it.
yeah.
What does it look like? And just kind of, and I care about the microbiome. So if I care about the microbiome, so therefore I'm obviously testing it, aren't I? And I think we can care a lot about the microbiome. We don't need to test it to care about it. We know a lot about other things that we can, just the kind of the basic things that we can do, which are really powerful to protect and nurture the microbiome. So I guess one of the things I'm really conscious of whenever we do testing, and I obviously do, and a reasonable amount of testing in my practice, is how that takes up time, and in our clinical setting, and I guess, yeah, whether that's the best use of that time, because that time could be used, just really kind of uh, coaching and supporting people in other ways. Yeah, and it's very detailed and heady stuff. So I think when families have got a new baby, like that's, is that really good use of where their brain should be kind of getting caught up in
Mm,
these specific details and wake up in the night and worrying about bacteroides or something,
yeah.
like, yeah.
Yeah. So you're kind of sitting on the fence a little bit, kind of, and also, is there something that, knowing what you know about the tests that are out there, is there something that is not in them that you would like to see
Um,
that we haven't spoken about? Like realistic reference ranges with
yeah, well, I think
accurate
that,
populations, absolutely,
yeah,
Um, but is there anything you kind of go, that would be really useful to know, you know?
I would like to have stool pH in there. That would be
Yeah.
nice if that was just
Mm,
included without having to pay a whole lot extra for it.
yeah, yeah,
Just that one marker.
yeah.
Um, and this is something to not have in them. I would like them not to give like automated therapeutic
Yes.
recommendations or linked
Yep.
to products that
I
people
agree.
should buy.
Mm. And
Yeah.
if they want to do that to the practitioner. Not
Yeah.
that I think the practitioner should be able to make their own decisions based on the person sitting in front of them, but not have that visible to the patient because they might
Mm.
just then self-prescribe or wonder
Yeah,
why
they
you
haven't
haven't
gotten to your
prescribed that.
appointment yet. They forgot
Yeah.
that you said don't take anything the lab
Mm,
said, and next thing you know, they've gone and bought all this stuff.
exactly. So
Yeah.
that's yeah, I don't like that either. Yeah. So I think we've spoken mostly about like what we see emotionally happening to parents when
Mm,
that are already anxious, receiving that
yeah.
report flagging imbalances and overgrowth in a tiny baby, and how that kind of might be super stressful for
Mm,
parents, and how sometimes that's often it's not necessary based on what we know about the dynamic state of the microbiome.
yeah.
Do you want to say anything to that before we move on to practitioners and what you've got available?
Sure. I mean, I think a really easy way of changing that would just be to like get rid of this red coding. Like,
Mm, as in when
just
it's in the red.
yeah,
Yeah, yeah.
and just make the report more neutral, and just
Yes.
clear that like I don't know, as we said before, that it's outside the reference range. We don't know what that means. It might be
Yeah.
healthy for your
Or then like
infant.
pathogen
Oh
blast.
yeah,
Yeah.
this is
Can we
problematic.
not put pathogen there?
Yeah, exactly. Yeah,
Yeah.
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 Yeah, and I guess in terms of harms, we do need to keep in mind the cost of the tests as well. Like
Yes.
they are expensive, and I think that I'd put that in like that's yeah,
Is it really
yeah.
necessary?
And
Is it a
like
good use
another
of their
thing that
money?
does happen sometimes is like this sort of amplifications of like different labs seem to amplify the read on different species. So it's important we're aware of that too. I think that's a real pitfall. Like Clostridioides difficile was coming up for just about every, and it is reasonably common in
Mm.
infants. It was coming up. I was finding just about every report with a particular lab, and then the lab did some recalibration, and then it wasn't. And you're
Oh,
like,
wow.
like, and when that comes up, you are, beholden to have to give, you
The
need to kind
conversation
of make
around it.
sure
Yeah,
exactly
yeah.
put, if your child needs antibiotics, then you should probably make these extra measures and, make sure you let the other health professionals know that this was picked up. Like, yeah.
Mm.
So I think that's, I guess, another thing, just being aware that the reports are not perfect. There are amplifications. And so to really, I guess, question something if it looks a bit funny, just a
Yeah,
repeat test if it looks a bit funny.
yeah.
Yeah. Yeah, I think.
So, for practitioners who choose to use these tests, what does genuinely responsible interpretation look like in this population? What questions should a clinician be asking before they even order the test, let alone act on the results? And we've
Mm,
mentioned a lot of these things during the
yeah.
conversation.
I mean, I feel like you could have just the cat, like the initial thing of like I think a naturopathic principle that we all want to follow is first do no harm. So just kind of
Mm,
think about, come from it to it from that
exactly.
perspective, like the financial costs, the time and focus, the parental anxiety, and then just the potential kind of overtreatment pitfalls that we could find ourselves in if we don't understand the test properly, or if we're relying too much on the interpretation guide, which is based on not good grounding. So I
Mm,
think that those parts, and then we got to think, okay, why do we want to do this test in the first place? Is there a clinically meaningful reason to do it? Consider the timing. You don't want to be doing the test early, unless there's a good, that there's a good reason to, and there's capacity to do the follow-up testing, and just being really aware of the changing nature of that ecosystem, and then be equipped to be able to put the findings in context. And you mentioned
yes.
that before, their age, their health, breastfeeding status. And I think it's really important to speak to the positive elements in the test. Give
Mm,
that good airtime, because I can't believe how many families where I just, you can just kind of, they really just see the negative things in there. So that
yeah.
if you can just start with letting them know about some of the positive things and giving them good airtime, you just see their shoulders relax and they go, oh, they're just so relieved.
Yeah,
They've
it's not
just,
all doomsday.
yeah,
Yeah.
exactly. But and also that, they're less likely to naturally remember the good things. So you kind of need to drive them in a bit, whereas we'll remember the things that worry us.
Mm.
And then just be ready to put that time into researching something that's unusual and you don't understand in that ecosystem, to try and put it in context and understand what it means for that individual. Maybe they've got, low bifidobacteria, but there's another organism that's actually filling that role because there's so much redundancy in an ecosystem. So just we've got to be ready to really try and understand the players. I mean, the good thing about an infant ecosystem, if we have decided that it's worth us testing it, is that there's not as many microbes to study in there. So
It's diverse.
it is possible to put that time in, but you do need to have, I guess, a decent grounding to do that.
Which brings me to your course. Can you tell us more about the Natural Early Life Health? Hopefully I've got is that the correct name?
Yeah, that's right. Yeah.
So who's it for? How can it help with this safe interpretation and application piece?
Sure. Thank you. So it's for practitioners, and I guess it's kind of the culmination of my years of practice and years of teaching, kind of bringing everything together, naturopathic and functional medicine approach to early life. So we're thinking preconception, pregnancy, postpartum, infancy, and toddlerhood, and providing a foundation in those areas, and then focusing on common presentations. So breastfeeding challenges, a lot of focus on gastrointestinal allergic manifestations. And of course, we go in depth into the infant microbiome and kind of, I guess, explore some clinical reasoning around when to consider microbiome-related interventions, when to test, and what to focus on in those tests as well. And my approach is, as you might have picked up from our conversation, is to kind of try and be humble and work alongside biology, and also to work through the mother primarily, and be really cautious about interfering directly with, or interfering. That was meant to not say that word, but that's kind of funny. Intervening directly with the infant, unless it's really kind of evident that that's going to be beneficial. So that I really feel convinced of that, weighing up the benefit and harms that could be associated with that, and really kind of feeling considered about it. So I guess for people that aligns with, they might find it's a good fit for them.
Yeah. Oh, honestly, if it was a demographic that I saw, I'd be jumping onto it, because I've done a lot of your courses for my own personal benefit, for my children and that sort of thing. I just wish I could have Dawn in my first aid cabinet every time I opened it up. Dawn, what should I be doing for my child in this department? Wealth of information. I wanted to hurry this along so that we can let other people know, so they can jump on board, so that you feel really equipped and empowered to use or not use these tests in clinic, and you don't feel very daunted by the information, that you can really put it into context. I think that, you are the place to go. If you're a Love and Guts listener, I have an exclusive offer for you. 25% off the course via the link provided in the show notes or in the YouTube description. One thing to note, however, is that Jason's Healthy Gut course is a prerequisite for this program. So if you haven't completed that yet, no worries. You can grab the bundle, which includes the Early Life course at 25% off, plus a discounted bridging course to get you up to speed. The link below has everything that you need. And please take advantage of this if it speaks to you. This kind of education is absolutely critical. Being able to safely and confidently interpret infant microbiome results is such an important skill, and this is exactly the training that will get you there. This offer is available until the 15th of April 2026, so be sure to check it out soon. Is there anything else that you want to say that you feel like we haven't addressed today?
I feel like we've covered it. What do you think?
I think so.
Yeah.
I think so. I mean, there's some positives. I think time will tell. I think over time, the more people use it, the more realistic the reference ranges may be.
Yeah, I
you
mean,
know?
as long as they're being sorted well,
Yeah.
like the data's been sorted well. Yeah.
Mm.
Mm.
And yeah, look, and I think hopefully some of these people that are developing them can take some of this information on board too, about what's relevant, what maybe we can leave off it, what we could potentially have in there instead, what wording we can use so not to be alarmist to parents, person
Yeah.
receiving the test. I think is really important to hear from us practitioners who might be going, oh, great, but oh, this part of it makes me go, how's that going to be taken? Anyways, I'm waffling on now. I
No,
always
that's a good
love having,
point.
yeah, I always love having you on, Dawn. I'm sure I hopefully will get you on multiple times in the future. Like I said, you're my go-to when it comes to my personal health. You're my naturopath. You've been my children's naturopath, and love all the webinars and courses and content you put out there. So thanks for joining us today.
Oh, thank you. That means a lot.
You're very welcome. And guys, if you've enjoyed this conversation or you know someone in your life that needs to hear it, please subscribe to Love and Guts so that others can fill up on the valuable content that Dawn has presented to us today.